Hi, Don here. Welcome to the $1 Million Minute, where we're trying to get your practice to the $1 Million mark and beyond. I'm going to talk about my most valuable kind of asset for the practice. It's called something called a dynamic demonstration. I got this idea from some marketing people, and they talk about you need to do something that will set your experience apart from what everyone else is doing. So, for example, if just taking plantar fasciitis as an example, if you just do what they can get online, you're really not doing anything extra, maybe except a cortisone injection or Shockwave. But if you offer them another paradigm or way of thinking about it, if you offer them additional education or ways of thinking about things that they don't have, it's going to set you apart. And specifically, I remember I was watching how the Good Feet store does it. We sometimes wonder how in the world can they sell a pair of orthotics or inserts that are over the counter for like $2,000 or $3,000 for shoes, and these inserts that are just plastic over the counter, and they call them orthotics. One of their ways is something called a dynamic demonstration. So what they do is they have people stand barefoot, and they kind of push them over or pull them forward, and then they have their hands clasped, and then they kind of pull them forward, show the instability, and then they put their little inserts things underneath their feet only, and then it makes them a little bit more stable. So this is called a dynamic demonstration. So it's something, if you want to watch, you can just Google these Good Feet store and just watch their little video of how they explain. But what's a dynamic demonstration that I do in the office? When I treat patients with plantar fasciitis, one of the easiest things for the majority of patients is to do foam rolling on the back of the calf. So we have a little ball. It's called an orb, O-R-B ball. A lot of people ask me who I get my things from. There's a company. It's not coming to me right now, but we get it on. You can buy it from Amazon, but we buy it in bulk so we can sell at Amazon prices with still getting the discount to make profit on it. It's called I think it's called Athletic Tech or Athletic Tech or something like that. So what I do is when I'm treating people with plantar fasciitis, as I'm kind of talking to them, I push in the bottom of their heel and it hurts, and then as I'm talking to them and teaching them, I'm rolling out the back of their calf. And I use a ball or a foam roller, and then this loosens up the back of the calf. And a lot of times by loosening the back of the calf, and I don't even touch the bottom of the foot, but a lot of their foot or heel pain goes away. We used to use something else called trigger point tools, TP tools, but they don't allow us to sell them anymore. And that was almost like a dumbbell type of roller that really penetrated deep into the back of the calf and the posterior tibial tendon, and it made their foot pain a lot of times go away. So you have them walk before and then walk after doing that, and then that's the dynamic demonstration showing that the foot pain goes away. So it builds credibility for patients. I would do it even with Shockwave if Shockwave worked that well. It does have a little bit of anesthetic effect, but I just wanted to share that one thing. So if you can, as many dynamic demonstrations as you can do that just kind of wow patients. I know other people do it with my colleague here, he does it with a functional movement screen. He has them do a partial screen to show their lack of flexibility and weaknesses, like a single leg stance and a single leg squat, and just showing how they're all wobbly, and then just kind of going back to, okay, you need to strengthen your core. So talking about things that they've never heard of, single leg stance, squatting, core instability, needing to strengthen your core, and all these things that no one else talks about. So for example, he also talks about belly breathing, things like that can activate these core muscles. So patients don't really always understand everything, but they're wowed because that's a demonstration that they never got of. Okay, so let's go into the day here. First patient was a 55-year-old with a right medial deltoid injury, Shockwave number 2 out of 4. This one, he also has kind of a subtalar joint bone marrow edema, so we're kind of doing that whole area in there as well. Next was a 19-year-old patient with right kind of heel pain. Looks like they had an ingrown toenail. They did an IND, and I gave this patient antibiotics, but they also had glass in the heel. They had glass in the heel, 19-year-old female, glass in the heel. I took it out, got an x-ray, did an ultrasound, did an IND, and then gave antibiotics. This was one that came from our urgent care website. Once again, I've been kind of talking about how this has really helped us, so we have an urgent care page, and we've been seeing many patients from this now. Next was a 51-year-old female, number 2 out of 6 for Shockwave for heel pain. Next was a 37-year-old female for left fibular fracture and chronic ankle pain. We did an MRI. The fracture is healing well, but she still has this ankle pain. Next patient was a 82-year-old male for right midfoot arthritis. We got x-rays bilaterally, and we're going to do orthotics for him to reduce the midfoot movement. We did talk to him about a meso brace, but a lot of patients don't like those, so that's why I just kind of talked about it, but I said maybe orthotics will be better. So usually, just kind of know my thinking, I'm usually talking to them about either the surgical intervention, then the bracing intervention, and then the orthotic intervention. No one wants surgery. Very few people want to wear a brace, even though it works a little bit better, and then people are more willing to do an orthotic or like a cortisone injection or Shockwave or something else like that. So I always kind of start out in like worst case scenario, and then kind of work my way back, and then it reduces their objections to the orthotics. Next patient was a 13-year-old female with a wart follow-up, and then after Cantharidin. And the next patient was a 65-year-old fractured fifth met on the left. She's status post 4 Shockwaves, and the gap is healing, and she's doing really great. She had a huge gap because it was like a transverse fracture, an oblique fracture, and it really healed in well, and it was really impressive for this patient. Next was a right 47-year-old female with right plantar fascial pain. She got my Pelto special with meloxicam. I'm going to see her back in 3 weeks for an ultrasound and possible Shockwave. This is one that wasn't ready to do Shockwave right away. I usually tend to kind of run right into Shockwave, but she wanted to try some of the other things first. Next was a 59-year-old female that had a cyst at the DIPJ. It returned, talked to her about doing a fusion in the future because she's drained it multiple times and used Coban, but it continues to come back. She also has bilateral heel pain, so we did an ultrasound, and we showed her that it was normal, so she's just going to do the foam rolling and things like that for her heel pain. Next was a 60-year-old female with left hallux limitus. And then she has right Achilles tendonitis, so we did number 1 out of 6 for her Shockwave for Achilles. Next was a 50-year-old male with left hallux that was wavy. We did a nail sample. He also had a left wart and an IPK. And so he didn't really want any treatment. This is not that common for me. For some reason, he wanted to get a second opinion. I'm not sure from who. He didn't want treatment, but we talked to him about doing lesion destruction and also Swift and Cantharidin. Next was a 63-year-old female for left foot. She had kind of a complex issue with her foot, a lot of pain, so we did an MRI for the foot and the ankle. Also recommended PT, and she had a lot of pain. This patient, took me a long time, that one. Next was a 48-year-old male with left peroneal pain. We did EPAT for this and also had some sinus tarsi, bone marrow edema. So this is number 1 out of 4 for this patient. Not sure why it was done 4. I think this one was maybe I got a second opinion with one of my colleagues, and they tend to do 4 Shockwave sessions. Next was a 75-year-old male that had gout follow-up. He's doing much better. No follow-up for this. Next was a 68-year-old Shockwave number 2 out of 6 for posterior tibial tendon pain on the right. They got new shoes. They're starting to feel better, and they're going to go through the rest of these treatments. Next was a 44-year-old female with left Achilles. Kind of talked about eccentric loading, and they also had a IPK, did lesion destruction on that, and I took a nail sample. They had a nail issue as well. I'm going to see them back in 3 weeks. If their Achilles isn't getting better, then we're going to do Shockwave. Next was a 85-year-old. She had midfoot arthritis. I did number 5 out of 6 for Shockwave for the bone marrow edema. Also, I did a sinus tarsi injection for her. Next was a 15-year-old female that had a wart. This was a LVP. You know what LVP is? LVP is a least valuable patient. So I had, that's my new abbreviation for this. So LVP meaning it's a level 2 visit usually. Wart was doing better. Maybe didn't even need to see this one back because she's feeling better. These LVPs, least valuable patients, I tend to put them in, double book them or put them in a 10-minute slot in addition to other things. So I'm starting to do that as well, taking these kind of simpler wart follow-up things and putting them into double booking them to 10-minute slots because they don't take a long time and they're really not most valuable patients. If I had like a nurse practitioner, I would probably transfer these to that practitioner. Next patient was an 81-year-old female, left first MPJ fracture, did an x-ray. They already had a boot and other things like that, did fracture code, and this patient as well came from the urgent care webpage. Next was a 41-year-old for left nail fungus. They did my Lamisil kit with Lamisil. Next was a 63-year-old with a bilateral fifth met head pain. Did an orthotic adjustment and a fifth met cutout in their shoe. Next was a 55-year-old for right Achilles pain. Did the Pelto special, meloxicam. See them in 3 weeks for possible ultrasound and Shockwave. Last patient of the day was a 71-year-old female for sesamoid fracture follow-up. They had no pain. Once again, that was an LVP, least valuable patient. So I'm trying to distinguish now what are the MVPs and the LVPs, least valuable patient or most valuable patient, just so you kind of keep your focus on how to get the most valuable patients better, faster, and how to reduce the follow-ups for the least valuable patients or double book them. So anyway, hope you guys found this beneficial. If you want, I was talking to you today about this dynamic demonstration. If you want to know kind of how I do that or have any other questions, shoot me an email. I'm happy to answer or walk you through that. Or if you have other things that you do dynamically that work well and kind of wow patients, let me know. I'd love to hear it. Don at podiatrypracticemastery.com. Okay, thanks.